This podcast is brought to you by Conquer Cancer, the ASCO Foundation. Our mission is to accelerate breakthroughs in life-saving research and empower people everywhere to conquer cancer. Welcome to Your Stories, a podcast where we hear candid stories from people conquering cancer. I'm your host, Don Dizon. Aside from simply being forms of cancer, what do esophageal cancer, testicular cancer, lung cancer, cervical cancer, and colon cancer have in common? Well, whether because they're linked to behavioral causes or because they affect portions of the anatomy traditionally deemed private, each of these cancers carries with it some type of stigma or taboo. The impact of that stigma can be detrimental. In some cases, stigmatized cancers receive less research funding, resulting in fewer innovations and advancements in both treatments and cures. Moreover, that stigma often results in patients hesitating to seek critical diagnostic care, increasing the risk that their cancer won't be caught until it's too late. April is National Cancer Control Month, which aims to cut the U.S. cancer death rate in half by 2028. Although better cancer screening is a vital step toward that goal, many people do not get screened, a problem made worse by cancer stigmatization. Today, we are joined by Dr. Stacy Wentworth, an award-winning oncologist and an expert in cancer survivorship. She has 2 decades of experience with leading patient-centered care teams in diverse settings. Dr. Wentworth also writes for Psychology Today and is the founder of the Cancer Culture Substack. In these forums, she explores how personal, scientific, and sociocultural factors shape attitudes towards cancer, including the various stigmas and difficult conversations that may come with it. Dr. Wentworth, we are very excited to have you on the podcast.
Hi, it's great to be with you, Don. Thanks so much for having me.
Absolutely. Before we get started, we always ask the same question. Let's hear where you are joining us from.
Well, I am joining you from Greensboro, North Carolina.
Beautiful state, beautiful city. First, tell us a little bit about what drew you to oncology, as well as the research you've been doing.
Sure. So I am a radiation oncologist. I came into oncology as a medical student. So I grew up on a farm in Illinois, far away from any doctors. And I had an aunt who was a nurse, and she went into nursing leadership in our local hospital. And she started in the mid-90s taking myself and my female cousins to the Race for the Cure in our local town. So I knew that there was some activity around cancer. And then as I moved into medical school, I was headed down the road to medical oncology when a neurosurgery resident actually told me that if I wanted to do just cancer, that I needed to do radiation oncology. So she sent me down to the basement and I wandered into radiation oncology and said, my neurosurgery resident told me that I want to be a radiation oncologist. So that's how I found out about radiation oncology, and they swooped me up, and I've just loved it ever since.
I think the smartest people I know are in radiation oncology, so I applaud you for that choice. So tell me, in your decision making around going into oncology, did anything in your past pique the interest of oncology and cancer medicine?
So not at that time. As I entered into residency, we did not have a strong family history of cancer. And now I have 2 family members who have both been diagnosed and died of glioblastomas. So I trained at Wake Forest, which is a brain tumor center of excellence, and trained with the wonderful Ed Shaw, who literally wrote the book on low-grade gliomas. So it was really very fortuitous that I was studying brain tumors as family members were being diagnosed with brain tumors.
Sometimes that can hit so close to home, can't it? It's sort of, trying to stratify this place as doctor as well as supportive person.
Yes, being on one side of the exam room, I know the rules very well of how to be a doctor and put on my iron shield of my white coat. But then when you're on the other side, it all of a sudden just says, that loved one becomes my loved one. And I always learn something by being with a friend or a loved one who's going through a cancer experience.
I find it changes you even as a doctor, but oftentimes for the better. You get to sort of see things almost more clearly, more like 360 ways.
Very much so. I had never had an MRI until about a year ago. I needed a brain MRI for myself. And just listening to that rattle trap experience really gave me a lot of humility in what my patients were telling me every time I sent them for a full spine MRI or a brain and spine MRI. So I think it is helpful for us to be patients every once in a while and to have to go through the process, especially at our own institutions, of what our patients are actually facing, from check in to communication to the experience.
I totally agree. And I think it's made me a better doctor just having that sort of vantage point. Let's shift gears and talk about some of your interests, which is fascinating to me because as someone who specializes in reproductive cancers, there's a lot about stigma in the field, particularly as it relates to, say, cervical cancer. But how did you develop and focus on stigmatized cancers and concerns around that? How did that all develop for you?
I started to realize that. So, one of the precious things we get to do in radiation oncology is see a lot of patients towards the quote unquote end of their treatment. So, they're finishing things up and coming to the end and getting ready for the next big transition, which is survivorship, which sort of drew my interest into cancer survivorship. And we have these weekly visits. And as I was unwrapping conversations with patients, it became so clear to me that what patients thought and what their friends, family, and loved ones thought the cancer experience was like was one thing. But then when the rubber meets the road and you're actually in it, it was something very different. And so watching patients need permission to live in that other world, to not be a hero, to be scared, to not be a fighter, to not want to be identified as a cancer patient, to really not want to be the woman or the man with cancer in a group setting, to how to say no thank you to people who wanted to offer very helpful but perhaps not evidence-based treatments for their cancer. Just living in those two separate spaces made me realize that a lot of what we believe around cancer as a society is still held on from 50 years ago. We still hold on to a lot of the stigma that's been attached to cancer that maybe was in the 60s and 70s, where no one was really saying the word cancer, certainly not saying the word breast on television or, in quote unquote polite society. And that even goes further back in Western society, all the way back into sort of the Victorian era. I realized how much conversation was stopping because of that stigma and how patients felt very separate from the communities that had supported them their whole lives once they started being diagnosed with cancer in many cases.
I think that is fascinating. And it begs the question about, how do these perceptions of cancer that we carry with us, maybe it's from how our grandparents dealt with it, which was in silence and it's almost shameful. How do you think these stigmas affect one's ability within families, the individual, even in neighborhoods and even in societies? How does that all impact the way they look at screening and prevention?
I could go on forever with that question. So I don't think that we can take the systemic nature of medicine completely out of screening. So as I walk in, I just assume people are going to trust me because I'm a physician. But I think that there are cultural beliefs and missteps and terrible things that have happened to medicine. So I do think that people bring in a lot of cultural experiences to medicine that we have to be aware of. As far as stigma goes, I think there's still, we just came off of colorectal cancer awareness month. And I think there's still the stigma of, I don't want a bag. I don't want a colostomy. So maybe this will just be hemorrhoids. See, and there's often stigma related to examining patients' rectums. I don't know how many patients I have seen where nobody's wanted to ask dear old grandma to unroll her polyester pants so that they can actually take a look at her rectum where a large tumor's been growing, but somebody has just been treating hemorrhoids out of deference and out of respect, but in a very negative way in terms of patient health. I also think that in young people, we have a tendency to really say, oh, they look good, they're healthy, it must be hemorrhoids, it must be just abnormal vaginal bleeding for cervical cancer. They don't, quote unquote, fit into what we would typically think as a presenting symptom for this disease. And as we're seeing this shift into young onset colorectal cancer, I think that really becomes an issue. I think stigma not only impacts patients presenting for care and perhaps presenting for screening tests, but I think it also impacts doctors. We have to not be embarrassed to ask a patient, hey, I need to do a pelvic exam. Hey, I need to do a rectal exam. I need to look at that. we really have to overcome that and get okay with touching our patients again. I think a little bit of COVID, a little bit of all the imaging that we do, but absolutely nothing takes the place of a first physical exam just to see if there's something going on that needs further workup.
It always strikes me, though, that it's almost become this negative symbiotic relationship. Sort of someone says, oh, it's just hemorrhoids. And the patient is like, well, although I feel a mass, they are the doctor. So it's probably just hemorrhoids. It's like this, I'm scared it might be cancer. You're saying it's hemorrhoids. I'm going to go with that.
Correct. Yes, absolutely. Nobody ever wants to hear the word it's cancer.
Right, right, right. And I think, it just brought up my aunt, non-smoker all her life, developed a lymph node in her neck. And her doc was like, it's probably pneumonia. You're not a smoker. And so she wasn't diagnosed until she was stage 4 with lung cancer as a non-smoker. And still, everywhere she went, people asked her the same question. How much did you smoke? It's like, you're not only worried about the stigma of cancer, but that cancer is the mark that you did something wrong, and I think that's truly unfortunate.
Not that you're just human, all of us. I'll tell you a story that really hit home to me. I was treating an elderly man with an HPV positive head and neck cancer. He's probably in his mid 70s. And he was a minister, a Southern Baptist minister. His wife had died. He'd married the choir director. And the choir director and the minister were in my office. We were talking about his treatment, and his family, his kids came in, and they heard that this was a virally associated cancer. And they started yelling at this little choir director lady that she had given their dad an STD and what a dirty lady she was. I mean, we had to call in social work, all this kind of stuff. Again, because of the stigma of this virus, before we could even sort of get everything, this is just an older patient whose immune system is not probably, picking up the HPV as fast. But again, it's sort of, what are we afraid of? I think if we go back to stigma, it's from the Greek, which is to point out, or it's at the tip of a point. And in the past, it might have been something that was most likely a communicable disease. So if somebody had leprosy, you wanted to get them out of the group so that not everybody died of leprosy. But I think in our modern communication, everybody is walking around with something. Gosh, if COVID didn't teach us anything, it's how can we more fully embrace what everyone is carrying and not ask them to put that away and not show it to us? Because we might judge them, we might shame them, and we might push them away. And cancer, out of anything, is the least amount of something that's caused by anything that you ever did. So I really want to get back to, is the stigma serving us? Like, how is it serving us to sort of cordon these cancer patients off? Not very well. How can we start bringing them into the fold? Because as we know, there's, an exponential increase in cancer survivors coming and people living with cancer. So we've got to figure out how to welcome people with cancer back into our worlds, into our communities, and to support them and to listen to their experience instead of foisting our own belief systems about what cancer should be onto them. I don't know. What do you think about that, Don?
Well, I think you're right. And it's also, we have to release people. I mean, I think you said it in the beginning, Stacey, it's just sort of this idea of how a cancer survivor should be. They should be pillars of the community. They need to be brave and speak about this struggle and how they came out on the other side and be that beacon of light that says, I had cancer. And if you're ever struggling with cancer or you get diagnosed, I'm here for you. Not everybody wants to do that.
I hear that a lot from young parents, and everyone's like, oh, you're so brave. No, I've got a 6-year-old kid on the other side of this and a beautiful life that I want. Like, this isn't a mountain that I'm like, yay, let me climb this mountain. It's just, there's no other choice. So it's not, with the other choice is just to lay down. And so I think that that fighting metaphor serves maybe us. It serves me to think that maybe when I'm hurting someone with my treatment, that they're a fighter so they can take it. But I'm not sure that it serves them when they just want to sit down and cry.
Yeah. So let me ask you the question then. So I agree with you that cancer does carry with it a stigma, for better or for worse, and how people take it on can be very, very different. Not everyone's going to react the same way. But Say you have those folks who are listening to us who really see it as something of an albatross, that they have to carry around. How can they get past that? How can they see cancer as something other than that stigma that they are carrying that is always going to be linked to them? Like they say, oh, this is someone's mom. She had breast cancer. How does one move past that?
The data shows us a couple things. One, it's how we refer to patients and how they refer to themselves. It does seem like patients who refer to themselves as a victim of cancer or that cancer happened to them in a very passive way, that they tend to have higher levels of distress, of depression, and more difficulty managing the anxiety related to after treatment. Whereas patients who say that they are a survivor of cancer or that they had cancer, those more forward thinking, I guess, ways to reframe the cancer experience, those words do matter. I also try to tell patients that many stories of patients that will come back to me 4 or 5 years later with a cancer somewhere else, or maybe a breast cancer on the other side, and they'll say, oh no, I just had one radiation treatment. Well, no, you actually had 5 weeks. And they forget, right? They forget that they came for 5 weeks. Sometimes they even forget my name, which is so wonderful that they forget one of their oncologist names because they're outliving their life. So I try to tell people that it's a little bit similar to watching a child drive off in a new 16-year-old car or leaving home for the first time to go to college. I remember that very well. It's a new experience and a new unknown. And you kind of have to trust those wobbly legs and to look around at the tools that have served you when you've been in different situations. Also, the cancer book is the only book on your shelf for a long time, but pretty soon it sort of goes over to the side. Like I've been trying to finish War and Peace since the beginning of COVID, and it's still on my desk. It's still on my nightstand, but it's way back in the back. I'm never getting to it. So I hope that identity as a person with cancer eventually becomes sort of in the background rather than in the front.
I think that's wonderful advice. And especially it goes into this thing that I talk about a lot myself is sort of the power of language, that we are influenced to how we state things, but also how other people see us, and that they just have this impact on us.
Sometimes I think we also, at least as a radiation oncologist, I think want to be so matter of fact. And sometimes I think it's okay to just be like, hey, well, why don't we just see what happens in 3 months? We'll just take it 3 months at a time, or we'll just take it 6 months at a time. And this is where we're at. And here we go. I do know a lot of patients think about radiation, of the terrible radiation that their friends and family had, even in the 80s and 90s, and don't want to even talk about radiation and won't even listen to me about, you don't know, or radiation caused the death of a loved one, and want to really process that. I think it's helpful to just say, why don't we just do the first week and we'll see how it goes? We'll just do the first week and you just decide if this is something you want to do or not. Very rarely in radiation is 1 week going to be helpful or hurtful. So why don't we just start the first week and then we'll have a conversation there? And sometimes I think that gives a little bit of that control back. Sometimes I try to talk them into at least a week of carboplatin or cisplatin or carbotaxol a little bit and just say, why don't you try it for 1 week? If you hate it, you don't have to do it anymore. But this is going to be your best chance for cancer. And sometimes I think that as a control freak myself, as someone just walking in and having every little bit of control wrest away from them, I think perhaps having that conversation is helpful.
I think our colleagues would be very good to heed your advice, Stacey. I find that instead of saying, I recommend you do 6 cycles of this if you want to be cured, it's almost as if we're giving this impression it's all or none, right? It's all or nothing. But what you said, I think, is a really valuable thing. There's power when you say, let's just try it. You can always change your mind. It's a sense of autonomy. Again, it's like you're fostering autonomy while you're hoping that they'll heed your evidence-based recommendation.
It's also how I got my survivorship program started, is that I found that nobody would say no to a pilot study, but if you say you want to change all of how people are going to follow their patients. So I just think it is a natural human instinct to try to say no to something, especially a big, scary machine or going into a lovely infusion center filled with very nice people. But man, nobody wants to be sitting there. So I think there's very rarely also any preparation work. And we're still very focused on getting patients into treatment as soon as possible. And even the chemo class or radiation orientation, I feel like sometimes falls on deaf ears because it's just in that wash of Charlie Brown's teacher of, yeah, we told you and we checked off the box and you said no and you went to this thing. But did we really do we need to come back now at week 2 where you really understand what it is and go over your meds again and do all that teaching again? You know what I mean? Like sometimes I worry that we're checking off all these boxes and I'm not really sure that a lot of that is getting through. So then people just sort of fall back to their base assumptions or what their friends and family are telling them. And then they see us not having a lot of time, so they don't want to bother us with questions or whatever. So I do think that it's one of the things I love about radiation is that every week we can sit down and I actually sit down, no computer. Hey, what's going on? Is this what you're expecting? Is it not? Tell me where we're at. Tell me how you're feeling.
I think that's also something that resonates. And I think it will resonate with a lot of folks that listen to this because I do agree with you. We have this regimen that we put people through. It's like, I recommend that you get to teach. We give you day 1, then you start, then we'll just complete the whole thing. And there's oftentimes not built into this idea of, and if we need to reevaluate, re-go over this, that's built into the system. So I find that in and of itself then becomes a stigma of cancer therapy because people are like, well, I don't want to become a cancer where I walk in a room and all you see is this cancer. It's like, I've heard that you don't even look at the people. You don't even know anything about my life. You just know me. Oh, that's my breast cancer and they're getting chemo. It's almost like we feed into that stigma.
I was at a cancer center and we had a new administrator come in and they literally put one of those deli counters with the little pieces of paper that you pulled off. That was the first thing that patients saw when they came in. Like, how about the message that you're a number? When you first thing you do when you walk in is literally take a number and then people call your number. So we had several conversations about that. But I think that people will go to a stigma and they will go to in absence of better or information that rings more true. And I think that as we're developing new relationships, people want to trust us, but they also have come from a system where they may not have experienced the best entryway to cancer diagnosis. We've both seen that. And so I think we're both building trust and trying to move a human to do something where there are pretty significant side effects. So if we can really help build that trust and then bring our teammates on, nurses, social workers, navigators, anybody that is on the team that's available, to provide a place for patients to let down and for patients to explore these stigmas and to say, this is what I'm afraid of. Oftentimes, I feel like it's what sort of gets caught in their throat that they really want to ask us, but they feel like they'll be laughed at or they feel like it's a quote, dumb question or something like that. Or, my friend said this or my friend said that or my pastor said this. And what do you think about that? I just feel like a lot of that is that old stuff that patients have enough to carry around that I really feel like sitting down with either us or another member of the team to sort of work through, well, why do people believe that if you open up a belly, the cancer will spread? Why do people believe that? Oh, that was from the old days. We didn't have CAT scans. They didn't know where the cancer was. So all they had was a surgery. You can kind of like put that little piece of medicine back together and work on that as they're going through treatment. But it's like building the airplane as it's taking off as well, because we don't have a month or two to sort of sit around and build these really great relationships when we need to get patients started. Especially, I feel like more and more with prior authorizations and all this other stuff, it's just delay, delay, delay. So by the time they walk into our office, it's like, we got to go because we've been staging and getting everything else going. So I do feel like that is a delicate balance that I'm honestly working on every day with every patient. I try really hard to ask every patient at least once a week. This is the patient dignity question. I don't know if you're familiar with Dr. Chanakov's work. He's from Canada. His work says that the one thing you can ask patients is, what do I need to know about you to take the best care of you? And that is the single highest predictor of how patients are going to do, what they want to tell us. And it sort of allows that goals discussion as well. I've really tried in every course of radiation to sit down and have that question with patients as well.
I think that's really wonderful. What a great way to sort of, even if you have that 10 minutes, it's like if that's the way you either lead off or end a conversation, what a great way to get to know somebody. So let me just ask, because you've talked a little bit about, say, head and neck cancers. I've talked about cervical cancers, both of which can be a very stigmatizing either because of the viral media, viral element in how it evolved, for at least for portions of them, but also because at least with head and neck, it's stigmatizing when someone gets treated for cancer. In your experience in the work you've done, can you point to any kinds of cancer where the stigma has lessened to the point where it's background noise rather than upfront for the patient or for the provider to have to deal with?
Yeah, so I'm actually writing a book a little bit about this, and I've just been in the 70s. So when Betty Ford announced her cancer diagnosis, it was about a month after her husband had pardoned Richard Nixon, and Nixon had resigned a month prior to that. It was an unexpected diagnosis, and she was determined that they would be completely transparent with the American public. She wanted women to know. You have to understand, this was during the Brady Bunch when they were getting a lot of pushback on Mike and Carol Brady. Even sleeping in the same bed on television was a huge deal. So no one said breast on television. No one said cancer on television. At that point, it was still what was called a one-step procedure. So women were put to sleep. A biopsy was performed while they were asleep. And if the biopsy was positive for cancer, they woke up with a radical mastectomy. Oftentimes, the women were not told that, and their husbands gave consent for their surgery, even in the 1970s. There was a journalist named Rose Kushner who was diagnosed a couple months before Mrs. Ford. She went to the New York Public Library and looked for a book on breast cancer. And there was one book on breast cancer. It was by George Kreil, and it was about the controversy of the one-step versus the two-step procedure. And so over the course of Mrs. Ford, Rose Kushner, of the breast cancer activists, taking their cue from the AIDS activists of the early 90s, we have really made breast cancer into something that is no longer a taboo subject. I've been going back and watching 1970s and 1980s television interviews. And in the 70s, it was perfectly legal not to hire a person who had cancer because the insurance coverage at that job wouldn't cover them. And also, people were afraid that they wouldn't be alive in 5 years. So there were many cancer survivors, especially women with breast cancer, who had hidden their diagnosis when they applied for jobs. Most notably, there was a Supreme Court case that happened with a woman who applied to work at the UN. So that is just 50 years ago, 1974. So that is only 50 years ago. And if we think about, my gosh, I mean, probably just logging on Instagram, we're going to find a million breasts there celebrating the different ways that women choose or not to have reconstruction after a mastectomy or lumpectomy. So I really do think that that has really moved forward. And then I think, again, just having come off of colorectal cancer month, the celebrities coming forward, like Ryan Reynolds going in or Gayle King going in and having a colonoscopy and talking about the Lead from Behind initiative, Jennifer Garner going in and having a mammogram. There are a lot of people that are sort of talking more about screening, at least. And as we know, screening is where the most bang for our buck comes, and finding things early. So I think in those ways, if we can start talking about butts, if we can start talking about rectums, if we can start talking about colonoscopies, I actually posted my prep on my Instagram and shared it with my Substack. So I guess that's a reason to sign up for my Substack. The prep was as bad as everyone says it was. So I think that by being more realistic with our patients, and if people can see other people, I mean, the reach of a celebrity is, a million followers. So if we can start asking celebrities or applauding them when they do that, I think that that's really helpful. And then I'm trying to sort of walk the talk and do it myself as much as possible.
Well, that's amazing, actually. So, very recently there was a conference that happened, and I stumbled upon this on social media, but they had a session called Rebranding Cancer.
Oh, I love that. I didn't see that. I love it.
What was so fascinating about it is that the quote was that they were saying the brand needs to be redefined because no one wants to screen because they might be diagnosed. And, I actually thought it like you did. I was like, that's kind of cool. But then I thought about it a little bit and I was like, boy, none of my patients wanted to be a part of that brand. And I'm not a brand ambassador because this is still a devastating diagnosis. And I think that's part of the issue. I think that we need to be engaged in that conversation with the celebrity persona. It has to be informed by our experiences as oncologists, seeing both, what the diagnosis looks like, but also what the aftermath looks like, both the good and the bad. I think this is where your work actually resonates as a counterbalance to this whole idea of branding, because you really are talking about reframing cancer, not as something to live or to die from, but that there is a larger middle ground of living with it. And it's not an enemy to be fought and it's not a war to be won, but it's a disease that either goes away or you live with chronically in a short time or in a very long time. But everything that you're talking about just reminds me of, the reframing is more important. And not only just for ourselves, but also for the general public.
I love that, Don. I love that reframing. The more I thought about, I got so excited about the rebranding, but you're right. It's a terrible product. I would love to not have a product to treat or sell. That'd be wonderful. But you're exactly right. How do we reframe it to lower the, emotional barrier to entry for cancer treatment and screening? Because that's what we're really talking about, right? Is let's eliminate cancer until there's some wonderful CRISPR gene that can come in and eat out all of our little P53 mutations. How can we lower the barrier to entry for patients? And that really, I think, is what has to happen. It has to happen that we cannot drag in this old history. I talk a lot about history because I think it's important. Like, why did this get set up the way that it does? And why is medicine the way that it is? Well, it's because of this. And if you see the structure, and it's like, oh, well, we created that structure around cancer. Let's create a different structure around cancer. Like you're saying, let's create a different paradigm around cancer where there is actually a place for people who are living with cancer. I don't even know that there's a place for people that are living with metastatic disease. I find those patients sometimes have the hardest time because people look at them and are saying, you still have cancer? How is that even possible? I thought it was either gone or not. So how can we reframe? I love that. May I borrow that reframe? I love that reframe instead of rebrand idea.
Stacey, that's your entire work. I was inspired by our conversation. I was like, you're talking about reframe. I love this.
And I think it has to happen on a higher level. So we can do it one-on-one with every patient, but I think truthfully, I treat patients, you treat patients to go back out into their communities and to rejoin the people that they have been around and loved them and do whatever they want to do with the rest of their life, not to just stay in our exam rooms. So how can we start fostering a community out there that can help support our patients when they return from cancer treatment? I think that it needs to go really big. And how can we start making that a welcoming conversation instead of, well, nobody wants to talk about cancer unless it happens. And to me, that's kind of too late. Like, how can we not normalize the cancer experience, but maybe just make it a little bit less frightening?
So one last question before I let you go. What does conquering cancer mean to you?
Wow. I think conquering cancer is living in a world where I don't have a job.
What else is there to say?
Thank you, Don. It's been so lovely being with you.
Oh, Stacey, this is just a joy. We could have talked all day.
I think so. Yes, very much so. So great. Thank you so much.
Thank you. Thank you for listening to this podcast brought to you by Conquer Cancer, the ASCO Foundation. Conquer Cancer is creating a world where cancer is prevented or cured and every survivor is healthy. You can make a gift at conquer.org/podcast. The participants of this podcast report no conflicts of interest relevant to this podcast. Full disclosures can be found on the episode page on conquer.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.